Okay, picture this. You're looking at the results of what's supposed to be a groundbreaking medical study. The data looks fantastic, the charts are perfectly aligned, and this new treatment seems like a total miraculous success. But what if I told you that the absolutely crucial part of that study isn't what's printed on the page, but what's actually missing from it? Today, we're diving into the mystery of incomplete data sets in this explainer, and we'll see how the systematic management of missing values literally determines whether a clinical trial is a genuine medical breakthrough or just a statistical mirage.
So, what does this all mean? What actually happens to a clinical trial when the patients just vanish? It's kind of a wild thought, right? But the stakes in medical research are incredibly high. Every trialist out there eventually encounters incomplete data, patients who miss appointments, surveys left half blank, or test results that simply disappear into thin air. We rely on these trials to tell us what drugs are safe. But when a significant chunk of patient data vanishes, we have to ask ourselves, are we still looking at the truth, or are we looking at a highly polished artificial illusion? Let's unpack the statistical mechanics behind this.
Okay, let's dive into this. Here is our roadmap for today. 1. The randomized baseline. 2. When data goes missing. 3. The attrition bias thread. 4. The illusion of perfection. And finally, 5. The intention to treat defense.
Section 1. The randomized baseline.
To really wrap our heads around why missing data is such a massive headache, we first need to look at the absolute gold standard of clinical research, the randomized controlled trial, or RCT. The whole goal here is to create a perfect prognostic balance between two groups. And why do we randomize? Because random assignment minimizes the impact of known and, crucially, unknown confounders. If we have a perfectly randomized baseline, the only difference between our control group and our experimental group is the intervention itself. This baseline balance is like a protective shell of internal validity that makes the whole trial trustworthy before a single pill is even swallowed. Let's walk through the timeline. We start with enrollment, move to randomization to get that perfect balance, and then we hit the intervention and follow-up phase. Finally, we end at data analysis. Now, right in the middle, that intervention and follow-up phase, that is the danger zone. That's exactly where our perfectly balanced trial is vulnerable, and where the problem of missing patient data typically sneaks into the picture. Patients enroll, they're randomized, but over weeks or months of follow-up, some inevitably disappear.
Section 2. When data goes missing.
Now, I want to reassure you right off the bat, not all missing info is a total disaster for a study. Trialists actually have to diagnose the underlying statistical mechanism behind those missing values. We basically have a clear binary here. On the left, we have data that is missing completely at random. This means the missing data points are distributed entirely by pure chance, completely independent of both the observed variables and the unobserved missing values themselves. Think of a clumsy lab tech accidentally shattering a blood sample tube on the floor, or a copier glitching out and ruining a survey page. But on the right, we have data that is missing not at random. And this is where things get scary. This is when the loss of data is driven by a deeply concerning clinical outcome, like a severe treatment failure.
So if our data is lost to a butterfingered lab tech or a busted printer, meaning it's missing completely at random, it doesn't actually introduce systematic bias or compromise the internal validity of the trial. Instead, it primarily just takes a hit on our statistical power. Power is simply the probability that a study will actually find a statistically significant difference when one is truly there. So, completely random data loss just reduces our statistical power without fundamentally skewing the underlying truth of the experiment.
Because this missing data is distributed by pure chance, it simply shrinks the final sample size. And when you have a smaller sample size, your confidence intervals get broader. This increases your risk of a type 2 error, basically a false negative, meaning you failed to reject the null hypothesis when you actually should. But here is the critical takeaway. It does not distort the true point estimate. It just makes finding the truth a little harder. It doesn't systematically bias the study.
Section 3. The attrition bias trap.
But what happens when the data loss isn't just a random mechanical glitch? A profound threat to validity happens when data is missing not at random. This means the probability that a value is missing is directly tied to the nature of the missing value itself. And this brilliantly illustrates attrition bias, which is a seriously dangerous subset of selection bias driven by the severe non-response. When a huge chunk of participants just vanish, that beautiful, perfectly randomized baseline balance we established earlier, it is permanently broken. Let's anchor these abstract statistical concepts to visceral, real-world human behaviors. Imagine a trial evaluating a novel antidepressant. If patients develop profound suicidal ideation or experience severe treatment failure, they might drop out simply because they're too incapacitated to attend follow-up visits. Or think about a weight loss medication trial.
Participants who experience significant weight gain might choose to skip their mandatory weigh-in appointments out of sheer frustration. Or in statin trials, folks experiencing severe muscle pain might just stop showing up entirely. These people aren't missing by chance. They are missing specifically because of the intervention. Section 4, the illusion of perfection. When researchers confront these complex dropouts, they sometimes make a really fatal analytical mistake. If a trialist mistakenly assumes that the missing data is completely random, they might execute what's called a complete case analysis by simply deleting every single patient with a missing variable. But if the data was actually missing not at random, the final results will be heavily distorted. Think about what this does. If you erase the depressed patient who couldn't get out of bed, and you erase the frustrated patient who gained weight, you create a highly polished artificial data set. You are quite literally deleting the treatment failures. Let's look at the stark reality of our analytical choices here. If you use a complete case or per protocol approach, you only evaluate the folks who finished. The result? Your benefit estimation is artificially overestimated, and your adverse side effects are ignored or severely underestimated. The true number needed to harm completely disappears from the data. But on the flip side, the intention to treat approach evaluates all randomized patients, which preserves the baseline balance and actually accounts for those harms.
I really want you to focus on this number, 1.0. In biostats, a relative risk of 1.0 is the null value. It means absolutely no difference in risk between the groups. When investigators use complete case analysis and selectively delete those high-risk dropouts, they are falsely pushing their skewed, biased data further and further away from this null value, inventing a statistically significant result that simply doesn't exist in the real world.
Section 5. The intention to treat defense. Let's directly compare these two philosophies. The intention to treat, or ITT framework, is all about accountability. It mandates that we analyze all participants exactly as they were originally assigned, regardless of adherence, dropout, or crossover. This preserves randomization and heavily increases external validity, meaning the study applies way better to the messy, real world where patients do occasionally miss pills or skip appointments. In contrast, per protocol includes only those who strictly completed the trial, which drastically lowers external validity and leaves the study incredibly vulnerable to selection bias.
Now, you might be wondering, how do we actually run an intention to treat analysis when the data is literally missing? Well, modern trials frequently implement sophisticated imputation techniques. Basically, statistical software looks at the patient's remaining observed data to mathematically estimate what those missing values likely would have been and fills in the gaps. This brilliant mitigation tactic allows researchers to keep the patient in the denominator rather than just deleting them from the study entirely. So the crucial point is this: to prevent the sneaky selective deletion of high-risk dropouts and maintain the absolute integrity of a study, we must demand intention to treat analyses. It is for sure the definitive gold standard for guarding against the bias introduced by data that is missing not at random, forcing researchers to account for every single randomized patient.
I'm going to leave you with this final thought to ponder. Next time you're reading a massive medical headline boasting incredible treatment benefits, ask yourself, who didn't finish the trial? In clinical research, is the data we don't see actually the data that matters most? Understanding how researchers handle the vanishing patient empowers you to see straight through the illusion of perfection and find the true clinical reality. Thanks for joining me on this breakdown, and keep questioning the data.